Yeah. Thank you for that very polite golf clap. I think you guys are going to loosen up a little bit. But listen, we're going to get started, and we're already going to call an audible, and we're going to start really now, not with our traditional kind of trip around the world like we do with Andrew Bolton. We're going to close that out with Andrew and George Andros, who are literally worldwide right now. But we're going to start with really an origin story, and that's going to be Toe and Flow, an origin story. It's going to tell a little story about how Joe Mills and I got together in clinic, but you're not going to hear from me on the toe side. You're going to hear from Dave Alper, who is a peripatetic podiatrist in and of himself, is now a member of the board of directors of the American Podiatric Medical Association, and they're going to get it started. Ladies and gentlemen, please help me welcome Drs. David Alper and Professor Joseph Loren Ramon Mills. Yeah, just amble. Oh, that's good. Nice. There's good flexibility there. I don't see any. Oh, okay.
Except for that.
Well, that would have been I would have taken a picture of that for sure.
Yeah, so there'll be another audible because despite getting my slides prepared and loaded earlier, apparently there's a problem, so they're reloading them. But anyway, I'm a vascular surgeon. Most of you know me. I was lucky enough to be the SVS president a couple years ago. We have Dave Alper here. He's representing the APMA. And they loaded, so we'll get right to work here. So we're going to try to do a joint presentation, and we've talked about this a little bit, but I haven't shared this podium too much with other people, except David and I do a little comedy act sometimes. But anyway, I kind of like this quote from Buddha in the middle. I like, if you don't change direction, you may end up where you're going. And I think that's true with diabetes. So I got this from Dr. Freiberg. But if you think about it, insulin was first used in 1921 or 22 after Banting and Best discovered it, and before that, diabetics died young. And then Jocelyn recognized this in 1934 paper. The people lived long enough, they got atherosclerosis, infection, delayed treatment, poor diabetes control, and ended up with amputations. And I'm a history buff, if you know, but the TMA was first used by the French for trench foot in the war. And then this paper, so I have 3 papers in a row that came out of Boston. So Boston was probably the place in this country where complex diabetic foot care started. And this is an old woodcut, or old picture from a book by McKittrick, and it shows that some of these patients, up until this time, BKA was the treatment for all these patients, and he got TMAs to heal in some of them. And then after Kuhn-Lin's publication of bypass, there was a remarkable series from the Deaconess of 1,000 dorsalis pedis bypasses, and this was all kind of happening when I trained, and that's still, and probably will always be, the largest series ever done from Legerfo and Pompicelli at the Deaconess. And then just to put things in perspective, why are we talking about this? This is a very recent article. So about 20% of patients with diabetes will get a foot ulcer. About 20% of those will end up with an amputation. And despite all the technology you'll hear about today and all the new advances we have, at least in this country and in some other countries in the world, the amputation rate is either flat or it's actually going up. So why is that? We need to do better. So this is a busy slide from Good News series, and I don't expect you to look at it in great detail, but all these are analyses of parts of the country where more vascular activity is done. So whether that's a bypass, an angioplasty, or even just doing vascular testing, the amputation rate goes down. So as a vascular surgeon, that made me feel great because I thought vascular surgery can fix this problem. We can identify these ischemic patients, we can revascularize them, and save limbs. And for the first third of my career, that's what I did. And then I started thinking about it. Well, blood flow is just one component. And as the demographics changed and we saw more and more diabetic patients, it became less clear who was really ischemic and who wasn't. And even in those who were ischemic, when we corrected, if you didn't fix the neuropathy part by some way, then patients didn't do as well. They recurred early. And all these things that are listed here, vascular surgeons don't really do. So I'm going to give my time here to Dr. Alper a little bit to comment on this. So this is just showing, if you look at what complete diabetic foot care needs, we don't do it all if we're vascular surgeons.
Well, thank you, Joe. And, it's always a little difficult to get the microphone, but thank you. I appreciate that. They trained me accordingly. The reality is the days of working in silos are gone. Marcus Welby and Dr. Kildare were great at taking you from birth to death. But nowadays, we cannot do it alone. It has to be a team. And fortunately, there were some visionary vascular people. Dr. Mills is one of them. I'm out of Boston, and so the Deaconess really led the way with people like Dr. Gary Gibbons and Dr. John Giurini, who saw that you needed to work together with the patient. How many times do patients go to their primary physician to have their diabetes checked and their socks never even come off? Nobody even looks. And this is where podiatry comes in, because we are the gatekeepers. When a patient that has diabetes notices a blood spot on the bottom of their sock, they're coming to me. And I'm certainly not revascularizing them. But I am going to be looking and treating at that wound, and I'm going to go into my Rolodex. Hopefully most of you remember what a Rolodex is. And are going to call my vascular consultant. We've been sitting here now for about 12 minutes. There have been 4 amputations in this country due to diabetes that could have been prevented. Half of them, 2 of them, will be dead within 5 years. And we know from the American Diabetes Association that 85% of these amputations are preventable with early intervention. And that's where the teamwork of podiatry and vascular care truly comes in, that we look, that we start dealing with the wounds. To your point, we do the offloading, we do the care of the wound, but nothing is going to happen until you get that blood flow. And it goes further, because if we don't get the endocrinologist in there to get that A1C down from 10.2, if we don't have the physical therapist in there to alter the gait, to take the pressure off of that, and it goes on and on and on. And this is really where the teamwork comes in. This is where we need to be looking. This is where they need to be looking. And this is where the collaboration comes in. And I challenge everyone here in the room, if you do not have a podiatrist in your referral base, if you do not have a vascular in your referral base, you are not treating this patient properly, because you're not going to get done what needs to be done.
Thank you. Yeah, so I made this up a little while ago. So everywhere I've gone, when you look at the path a patient with a simple diabetic foot ulcer follows, it's a maze. So when I was in the Air Force, if the foot was warm and there was a Doppler signal, it went to orthopedics or general surgery. We changed that. When I went to Arizona, similar thing, we changed that. And we did it all with just vascular surgery. But I kind of got to think after a while that just isn't enough. But you can kind of look at this random pathway here, and the same thing showed up when I went to Houston 11 years ago now. Had great care. If you had an aortic valve problem or a complex aortic aneurysm, you got world-class care. If you had a diabetic foot ulcer in our system, this pathway could have been any one of these, depending on who saw you that day and who they referred you to. So that seems like random care is not a very good thing. So then it shows you all the connections with DFCon and ALPS. But in 2008, George Andros and I went to Italy. A man named Graziani had a course on below-the-knee intervention, and he has a classification, which actually is pretty good, but too detailed for lower extremity arterial disease. But he was doing tibial interventions, which at the time was relatively novel, and long-segment tibial interventions. So I don't know if you know this. We went to Rome together, and this is the famous statue from Bernini. It's the Fontana dei Quattro Fiumi, and so it's the 4 great rivers of the world. And so I'm looking at this statue, and I look at this, I take this picture, and that's kind of where the toe and flow idea came together. So obviously you need blood flow, but just providing blood flow, it's kind of humbling. That's not enough. In a lot of these patients, that's just a part of the story. And I don't like to see posts on the social media and stuff as somebody presents an angiogram and there's flow and let the healing begin. That's just the first step of a long journey for most of these patients. So this is a slide I borrowed from David, but there was an older study, I think this was from Duke, but they just looked at the role of a podiatrist, and if a patient with diabetes saw a podiatrist and one other medical specialist in the previous time period, they had a reduction in amputation. So podiatry is really important. So David and I decided to work together in Arizona. We founded SALSA, the Southern Arizona Limb Salvage Alliance, and we set up this thing where basically our 2 services saw every patient. We kind of triaged them largely based on Wi-Fi and decided is this mostly a flow problem or a wound and offloading problem, and there's a lot that are in the middle, so then you have to decide together how you're going to do this. Then we got this bigger idea of how can we make this idea bigger, because doing something in your center or in your community is good, but it doesn't solve the problem. So to his credit, we had this summit in 2009 in Tucson. In the middle is Pat Claggett, who was the president of the SVS at the time, and he wasn't a big person into limb salvage, but he thought the idea was good. On the far right is Wayne Ziefelt from KCI, who helped fund this. Next to him is George Andros. There's me unshaven, Becky Marin, who was the predecessor to Ken Slaw at the SVS, and then Russ Taubman, David with his goatee, and Glenn Gassworth. So this was the first APMA SVS joint summit which led to this supplement was published in the Journal of Vascular Surgery and JAPMA, and it was a joint publication. And the idea was to try to encourage people to build toe and flow teams. So, and if you look at the pathway from a patient with an intact foot who then has loss of protective sensation and sometimes motor neuropathy and then ulcerates and then has infection, that's what drives most amputations. But there's vascular disease in there, right? So if you look at how a podiatrist and a vascular surgeon would work, we overlap really well. So when I came to Baylor, what we did was the same thing. Every single patient got seen by podiatry and vascular surgery. We staged them with Wi-Fi. If they had drainable infection, that was the highest priority. Next on the list was ischemia if it was there. And then we meet regularly, even talking all the time. Sometimes we miscommunicate. So on Monday, we go over every single patient and figure out, like, if somebody stalled or we've missed something here. So it's just a relationship, like a family.
And the key is, too, is it doesn't stop when the wound is healed, because these patients need to be monitored. You know, I don't think you have a slide of the incidence of recurrence.
Thank you for bringing it up.
There we go. Foreshadowing is a wonderful thing. The point of the story is that you need to be part of these patients' lives, and they want you to be, because they need to learn, they need to be monitoring themselves. But a typical diabetic patient will see their podiatrist 4 to 6 times a year. They're not seeing their GP. They're not seeing their endo that often. They're seeing us that often. And that's why recurrence is very often as dangerous as the initial visit, and why these types of relationships continue long after things are healed.
Yeah, so this meta-analysis, there's no prospective randomized trial because nobody's really going to do that, but it just shows that when you have a team taking care of these patients, almost no matter how you constitute the team, the patients get better care. I think that's true. So this alludes to your point. This is from Stefan Moorbach. So in our country, it's harder to get recurrence rates because patients jump around and some have insurance and some don't. But if you have a national healthcare system, you can do that. So if you look at this, it's pretty humbling. Like 60% of these patients, I mean, they have another limb, right? And they still have a limb at wrist that was healed. 60% have a recurrence by 5 years, and by 10 years, it's virtually guaranteed, 97%. So that comes up with the concept of we're not curing these patients. Like, diabetes is not cured by insulin. It allows you to treat it, but it's not a cure. And what we do for these patients is not. So we're not negative to the patients, but we try to get them into the idea of, you know, we've got this foot healed now, this is great. Our goal is to keep you walking and independent and keep both feet healed as long as possible. And so the closing part, bear with me for a minute. So I started thinking about what do we have to do, because we have this huge wave of diabetes. And I started thinking about the Netherlands. So that picture there is the North Sea. If you've ever seen the North Sea, it's pretty formidable. And for sailors, it's pretty formidable. And if you think about it, half of the Netherlands is below sea level. So how do they prevent being flooded all the time? So on the left here, there's a physicist in the audience, so I'm not going to go too much into the physics of it. But if you look at the physiology of waves, and they strike the shore, if you build a high wall, and the wall analogy is Dr. Alper and I and vascular and podiatry people, with the people that get bad foot ulcers bad enough to get admitted to the hospital, leak through the wall, and we're putting our finger in there trying to wait for the next one to come on, that approach doesn't work. So building a bigger wall is not a barrier. So what we can do with diabetes, which you really can't do with the ocean, is we could theoretically reduce the volume of the waves that come through by prevention, by outreach, by solving problems with food deserts, by doing foot CPR, have people check it. So that would be one way to reduce that. If you look at the middle, this concept is interesting. So that with the waves, if you build a big wall, the waves will knock it down. If you build what the Dutch call a wide green dike, it slows the wave propagation and reduces the risk of flooding a lot, even though it's much shorter than the big wall. So what do I mean by a wide green dike with related to diabetic foot disease? Well, high-risk patients should be referred to a multidisciplinary clinic. If they have high-risk feet, they should be followed by podiatry. The podiatrists have an algorithm for patients with risk factors and how often they should be seen. Most of our patients don't get that. High-risk PAD should be referred to vascular, not so they need an angioplasty or a bypass, but to have a conversation about how bad is their ischemia and what risk factors can we work on to prevent you from coming through this dike, okay? And then we need to get other specialties involved. So it's not just toe and flow. We need internists, family medicine people, endocrinologists especially, to examine feet and to help us control the blood sugars. Then the picture on the right is actually Amsterdam, which is amazing. So if you think of canals and bridges, those are basically connecting points where we have different specialties, not working in silos anymore, but we make it easy for the patient to get from one place to the other and don't have barriers. So this is a statue. When we did the global guidelines, we presented them in Lyon for the first time. I know Mike was there. And this is a statue in the park there, but it gave me the idea of this is something we need to all work on together. This is not something that any one specialty or any one group can tackle. It takes an effort. And while I love the collaboration we have with podiatry, we need to build on that. We also need to extend it to other specialties.
Absolutely. I mean, we're talking about dietitians. We're talking about physical therapists. You know, one of the wonderful things that David and the organization created was the 3-minute diabetic foot exam. This should be done at every visit, at every patient visit. And it's something that every specialty can do. I myself teach it at PA programs because it doesn't require equipment. It doesn't require deep knowledge, but it does require a look. And at the end of the day, this is what it comes down to. The more eyes on these feet, the more likely we're going to get that early intervention, the more likely we're going to be able to prevent.
Yeah, so I always close. This is a team effort. So we have about 15 vascular surgeons in the St. Luke's Baylor system, but the toe and flow team is primarily 5 vascular surgeons and 3 podiatrists. And this work requires all of us. And we also have vascular lab techs, MAs, PAs, all kinds of people, prosthetists. And you can't do this work alone. So one of my favorite proverbs is attributed to Africa, but it's if you want to go fast, you go alone. If you want to go far, you go together. So I mean, to make a difference in these patients' courses, you do much better when you build a team. And I find it professionally fulfilling. You learn from your partners. And I was talking to Georgia before this talk, and you'll hear about technology here. And when new technology comes out, we all want to learn it. But if you think about the way this meeting is structured, it's not structured around technology, because I would hold that if you get enough people from different viewpoints looking at the problem, you'll talk to each other and you'll learn from each other, and the technology will come with it. And you'll adopt the technology when the time is right and not be a premature adopter and move on to the next balloon or wire or whatever for something that doesn't work. So that's the big goal of ALPS, is to promote interdisciplinary collaboration. And I'm glad you're all here this morning and proud to do the introduction with you, David.
Very well. Thank you so much.